Dr. Kristy Soloski, welcome to the show. Glad you're here.
Thanks, Nick. Thanks. Glad to be here.
It's been almost, I think, maybe 6 years since we've seen each other in the flesh.
Mm-hmm. It's the first time I'm getting to see all this fantastic work in person, get to see what it looks like, how the people feel.
So before we dive in and get started, I want to give you some flowers and ask you to introduce yourself.
Yes. My name is Dr. Kristy Soloski. I am a faculty member in, I guess I could say the place. I'm in Texas Tech University. I've been there for 11 years now.
Wow.
I'm also a licensed marriage and family therapist and a licensed chemical dependency counselor, and I've been practicing in Texas since 2017, but if you include my training before then, so that's also over 10 years, almost 15 years now that I've been practicing clinician. So I work to both train clinicians and the future generation in a lot of different areas, one of those being statistics, the other being working in culturally diverse communities and identifying the needs for them. And yeah, that's me.
And among those many things is the associate chair of the department.
Yes.
Is being asked.
Minor things.
Asked to lead, to continue to lead,
yeah,
you know?
Potentially,
No, I just mean like being the associate chair.
Yeah.
Like that's different than, being in that tenure track role or being a tenure track or a tenured professor and what that entails. So I'm a product of those programs that you work in, so I did my undergrad, my master's degree, and my PhD all in the same department across different programs, some of them, but in the same department. So we got to know each other really well through those years. And then in particular in my PhD program, well, a little bit in the master's because I took stats from you.
I think you were one of the first cohorts in the program when I came in as a faculty.
That's right. Hashtag Stats Excite for those that will remember that project. That's a deep cut for like 5 people in the world.
Nerd.
And then I officed outside of your office.
Yep.
To be clear, not inside of an office. I was inside of a very nice cube outside of Kristy's office for a number of years during my PhD program, which was one of the things I love about MFT programs is you get this introduction into research, you get an introduction into teaching, so likely you'll have an assistantship where you're managing your own class or helping a professor manage a class, in addition to your clinical responsibilities and your coursework, which could be a myriad of supervision, live supervision,
Minor things. You have a ton of free time in that program.
So I was in that cube like 12 hours a day for several years, and ultimately you became a good mentor and my dissertation chair who shepherded me through the trauma of figuring that out. So I am grateful.
Well, you are our golden child. No, you, I think, impacted me as a professor in a variety of different ways. I do joke about you being my pride and joy. I appreciate the journey that you've gone on and the way that you've taken what you learned to go to a place where you can make a real impact, and you traversed a pathway that nobody else had gone on before. And I've always thought that was so courageous, and it's been an honor to watch how it's grown and developed over time. So
thank you. Well, I remember processing these decisions in your office too. So I'm absolutely a product of that program, and just a shout out to the whole staff, Nicole Morlock, Sterling Shumway, Tom Kimball, you, Doug Smith, Nicole Springer, and so many people I probably just forgot, so I shouldn't have done that. But Cynthia D'Souza, Kitty Harris, Vince Sanchez. Okay, I'll stop.
the whole crew.
Like just all of these people that do a great job teaching people how to grow.
I think that's at the core of it. That's the hope. How do we help people be the fullest? How do they get to the fullest capacity that they possibly can? Be the best versions of themselves that they can.
Which is a good segue, because look, this is a podcast put on by a treatment center.
Yep.
And the reason we put it on is so that we can, be a window into what we do and to help people understand maybe what behavioral health is and how it manifests in addiction treatment and how that matters for somebody that's maybe looking for treatment.
Right.
So as an MFT, which is sort of like an arm of the tree in psychology, you are taught in systems theory. So I just wanted to really ask you, like, from the jump, like, what is systems theory and how might that be applied in addiction care?
Yeah. System theory is a way of thinking about the world and how we as people are interconnected. So it's taking this perspective that instead of us being siloed individuals that are traversing the world, it's this understanding that none of us are doing any of this independent from other people, other networks, other situations, other societies, that we are all living in a connection to one another. If we take it down to the family level, it's this understanding that families develop behaviors, patterns, interactions together as a unit, not independent from one another. So the system is the family. It's everybody that is living together within that family unit, and maybe even the extended family as well. But any problems that pop up aren't because of one member of the family. It's an effect of the interaction patterns that the family has developed and created, and then they become self-perpetuating as well. So the most famous explanation of this that we give is if you think about a baby mobile that would go over a crib, they often have these little arms that reach out and little figurines that are hanging from each of the places on it. And if you pull any one of those legs of that baby mobile, the whole thing's going to shimmy and shake. Right. And so that's what we see happen in families. If any one person stumbles and falls, the whole family feels it and reacts. It could also be that one person stumbled and fell because somebody else pushed them, somebody else rocked the boat, right? Something else happened within the system that then there was a reaction, and that reaction was that person falling. So if we take that then to addiction, I would say that anybody who's developing problems with substances is doing so amidst a system that is perpetuating a problem that is then coming out in the form of substance use. So I would say that one person developed that problem not because of just something inherent within them, but because of something that was happening within the system that they then had anxiety, frustration, something that led them to then make that choice to use. And that's the way they stabilized their feelings, was through the substance use.
Yeah, that's a perfect answer. And not to be confused with, like, addiction is caused by your family.
Right.
That's not what that means. It just means that, like, when we're unpacking and trying to understand the nature of somebody's individual problem, and perhaps importantly, how they build a structure for success into the future, that the baby mobile analogy is helpful, that you are not, change must be considered in the context to which you're developed and exist. Yeah,
that it's a reaction from the system, not just one individual's choices and reactions. If I were to expand it and give an example, I would think of let's say you have a family unit, and let's just pick a stereotypical family unit. Let's say you've got a mom and a dad and two kids. And let's say mom and dad are having trouble in their relationship, maybe from the different backgrounds they came in. Maybe one of them experienced trauma in their family of origin, whatever it is. Mom and dad are having problems. And one of the kids just stumbles upon that when they come into the room when mom and dad are fighting, and they start like dancing around, having fun, making jokes, that mom and dad stop fighting, then they learn, and the family learns, that this child can be our stabilizer, the mascot for the family unit, if we look at family roles that people could fall into. And maybe then that child always is the mascot. And so when other people get frustrated around them, they find a way to be the one that's going to dilute the frustration that other people are experiencing. And so they act out, and they're often the comic. They're the person who is the stand-up comedian. They're the funniest person around you that you know, but deep down inside,
de-escalating the conflict.
Yes, their role became de-escalating conflict, and maybe the family members needed them to serve that role. It kept mom and dad together.
What's funny about this, like talking about examples, is like my experience, because everybody is the protagonist in their own story.
Yeah.
You are the main character.
I am the main character.
Right?
Yes.
When you reflect on your own family, you're like, we don't do that. Like, we are vulnerable. We are authentic. Maybe you do, maybe you don't.
Yeah.
We are healthy.
Absolutely.
And my experience individually has been, not to say, because my parents, God forbid, I don't want to get a text like whatever, but, it turns out we're somewhere there in the middle.
Yeah, absolutely.
And it turns out that that way of thinking from a systems perspective is very useful to sort of unpack early recovery in a family of like, oh, wow, I can see myself as an example. I can see how my sister like really bailed on the family to survive again, like what I mean by that, she went away for college.
Yeah.
We grew up in a college town, went away for college and was like very academically successful. She was the hero, right? Whereas I was the victim in my own mind. Not anybody. I'm not saying I was a real victim. I just played the victim role, and my parents were just doing everything they could to figure it out, everything in between. So it tends to be helpful language, like in our family program, like that early, like that initial, like new idea of like, whoa, what is this? Whoa, am I involved in this? Because I was just coming here to support Kristy.
Yeah.
And turns out there might be like this other level of...
Right. And it's probably that everybody in the family is struggling with something, and maybe it sometimes manifests as addiction. Maybe it sometimes manifests as just a normal, standard, everyday anxiety disorder, where they're feeling anxious and nervous about something all the time, and they just don't use, but they are still struggling in some capacity.
Do you think, I was going to ask you if you think that treatment centers, in your experience, do this well in terms of the acknowledgement of family care?
I think they are working really hard to integrate that as a crucial member of family care. I would bet, because I haven't worked in one of those treatment settings and I haven't been to many of them to see how they're doing it. I just know that I've heard a lot of treatment centers integrating family week groups, et cetera, into the treatment process, which I think is phenomenal and great. I wonder from an outside perspective and someone who's not been in any way, shape, or form part of the treatment, whether the family members really get it, that they also need to change, or they might not also experience the benefits of the treatment piece, or they might not fully really understand the role that they might be part of the development of the addiction itself, because that takes a lot of responsibility, and they themselves haven't sought treatment by being the ones that aren't in the treatment setting. Maybe they have external, maybe they're going to their own therapy outside, but I'm just imagining that the majority of those family members are probably not also in their own treatment.
Yeah. One of my favorite things about recovery, it kind of reminds me of what you're talking about, is that recovery will invite you to grow in ways that you least expect.
Yeah.
So I think one way to say what you've said that I'm thinking about differently in this moment is when you show up to rehab, the problem is addiction. Hopefully when you're leaving, the problem is how can I better cope and problem solve with life on life's terms. And how am I going to continue to grow into, I'll just say, a better version of myself where I can be maybe happy, joyous, free, more vulnerable, more self-directed than my anxieties or my trauma or my depression might be disallowing me to do. And ultimately, that's what you're talking about with families is like it's really an invitation to grow beyond what you might think is related to addiction or not. That's
absolutely
ideally what somebody's going to walk out with.
And change is hard. Systemic change is even harder. One person changing is one thing, but if the whole family is changing, that's a whole different piece, and that takes a whole extra amount of energy for that to happen. Everybody would have to be engaged in the process to make that happen. Go ahead.
Can you talk about what's unique? Because what you are an expert on, and you're a part of an expert team, is this like integration of your department. I'm not going to rattle off what that means.
Yeah.
The different programs and the center. Can you unpack that a little bit?
Our layout of our program,
sure,
and the different elements
how
of it.
that might equip a professional
Sure.
to. I mean, it's unique that you guys are so focused on addiction.
We are.
So talk
we
about
are
that.
probably one of the few programs in the country that has such a strong addiction focus. Are we the first PhD program in addictive disorders?
Yeah, and let me back up. Let me set the table.
Yeah.
Because most graduate level psychology programs, LPC, social work, MFT, yes. I'll leave out clinical psych. They want to be left out. It's fine. I'm just kidding. I'm joking.
No hate. Yeah.
Nobody come at me. But those professions, generally speaking, on average, you are getting the exposure to one class associated with addiction. One.
Yes.
In all of your training program, 60-ish hours in a master's level program.
Right.
Right.
And 5% of that is addictions. Yeah.
Yeah. I mean, that's like, oh, wow. How much addiction do you see in your private practice over the last decade?
Actually, a lot, but that's because I assess for it. So,
but like more than 5%.
Yeah.
You know, probably.
If we include behavioral addictions, definitely.
Yeah. So one thing that's really unique about tech is at this university and this college and this department is like they're just like complete embracement.
Yeah.
Of addiction and recovery. So you can talk about that.
If I can go back a bit. So I wrote a paper on this once. It was for a magazine article, I think, and it was partially on the marriage between marriage and family therapy and substance use treatment. And that's in part, the field of marriage and family therapy was partially born through the addictions work that they did. That the field itself was legitimized by incorporating families into the treatment process. And yeah, that's one of the first research grants that came to our field was an addictions-based study that they were working on. And so I personally love to see it at the core of our field because it is part of the birth of our field into modern day area, right? Like we were then eligible for different research grants. We were recognized in that capacity that it opened the door for additional research grants to happen. It opened the door for us to have insurance reimbursement for the clinical work that we do. So we really were born from that. And the program that I'm in at Texas Tech, we have within our department 2 programs, one that is marriage and family therapy and the other that's addictive disorders focused and recovery focused. So we have both of those elements that are part of it, and we work together and see ourselves really as a core that within addictions, we understand that systems were part of where addiction came from within them. And within the family side of things, we know that people will struggle with, you're going to have clients that are struggling with addiction. And so to think that you're going to do marriage and family therapy without understanding how addiction might then be part of the family process would be wild, because you're definitely going to get people coming into therapy who don't yet know that they are struggling with addiction, and that's why their marriage is on the rocks. And they haven't quite figured it out yet, that that's the element that's at play for them. So for us, it's just integral that we're thinking about both things.
What's interesting, or a coincidence, so the history of addiction related to MFT and growing the field, but also the core components and assumptions that exist in recovery, like almost like a transparency slide for those that are old enough, like in school, where they would like write with these, on the thing that would shine up on the wall, and then they would change the sheet, and then somebody's job would be to like squeegee it. Anyways.
Yes.
Not to take that too far. It was dark.
Nostalgia.
Yeah. Is that my brain is so strange because I was thinking about how things overlay, and I went to transparencies in middle school, so it's fine. But when you think about the core concepts associated with recovery, they overlay the core theories and assumptions within systems almost perfectly.
Yeah.
Like, in order to participate in recovery, you don't have to believe that it's going to work for you.
Okay.
So like in systems, it's not Doug Smith's trauma, of taking his, like reading cybernetics, which is like a wild thing to ask graduate students to do, is like the headiest book you can think of, like completely not accessible. He's not going to find this funny at all, by the way. But I love the book. I remember it. I'm talking about it now. So it
He will
worked,
never
Doug.
not give that book.
Yeah. But like change doesn't care about what you think about it. Right. So like when you're approaching like a systems perspective, it's easy to get sucked into like, let me try to help you generate insight.
Right.
And in addiction care, I think there's an assumption that like we're going to talk through this problem and thus your behavior will change.
Right.
Negative.
Right. Sometimes there's no amount of talking that's going to, but that's core to my theory too, that I don't believe that talking's sufficient to create change. I think doing is an integral part of change, that we've got to do something different and experience the outcome of that difference in order for us to be able to make change.
And even sometimes the process of exploring my difference in doing is the change in of itself.
Experiential.
You know, and so like recovery, like think about it, like you show up and you're confused and they're like chanting and there are certain readings and there's unique language and there's like a structure to this thing and like people hand out coins and you're like, what's going on? There's a basket. People put money in a basket and you're like, wait a minute, am I in church? Am I not? Why is this happening?
Right.
And in therapy, for somebody who's not a therapist, likely you're here and you're like, is this going to help me? I just showed up. There's unique language. You know, like how is this structured? Where are we going? What exactly is going to be on my treatment plan? How did you decide that? So other domains of psychology are very focused on insight.
Yeah, they are.
And MFT is not. It's about adjusting the inputs and the outputs of your life. And Doug always used the example of like this black box in a science spectrum museum.
Okay, yeah.
Where like you pull on a rope over here and you don't really know how it's connected because it affects something over here, but that's not really our job. Our job is to sort of just keep manipulating it until we get the desired output.
Yeah, you got to shake things up in order to create change. You got to, because if we're going back to systems theory, every system creates a homeostasis, a normal way of being, how they operate on a daily basis, what the roles and the rules and expectations are for the family. And so if we want something to change, we've got to change the structure really. And so you've got to increase the anxiety and shake things up and see if we can then roll out something that's different than what it was before it went into it.
Yeah. People probably haven't heard that before, that in order to create change, we should actually increase the anxiety. Will you talk about that a little more?
Yeah, and I'm going to also say that anxiety is not always a bad thing, right? I worry sometimes that we have gotten to a place where we think that feeling bad feelings is something that should be avoided at all costs. And actually, anxiety, I think, is a really important part of our lives. Our bodies are built to feel anxiety. It's a informational process within our body to tell us that something is going on that is either just new or potentially even dangerous, that something is happening within it. And so feeling anxiety is a very good thing. It has a role and a place in our lives, and I hope that we can all accept that as an important part of our life, not something to be avoided at all costs. For a system to change, though, we've got to do something different. We've got to do something new. And many times our bodies register that as being dangerous and scary because we're walking into a field that we don't know what predators we might be experiencing. We have no understanding of the path in front of us and what obstacles we might be facing. And so people will choose the path they know more frequently. They know what dangers lie. They know how to avoid those dangers, and they just want to keep going down the same old road. But if we want something to be different, we've got to do something different, and we often don't do something different unless we are pressured to do so. So that's also where the anxiety comes in. And in addiction work, I think that shows up where people are saying, I hit rock bottom. Life became so insufferable and uncomfortable that I couldn't do it anymore, that was bad enough and I had to do something different. That anxiety can create somebody then seeking help, seeking support.
It's interesting because one of the things as an organization we challenge ourselves by is how to communicate or be known that addiction care doesn't always have to be emergent.
Sure.
Like, particularly detox and residential care, clinical indication of those higher levels of care. So for those listening, levels of care, from detox, residential, intensive outpatient and outpatient being what you would consider like private practice where you see somebody, for an hour every week. residential care being that you're receiving a certain number of clinical hours per day, and you're likely staying overnight at a facility, and it might be 8 hours a day or what have you, depending on the state. Most people, addiction develops into this place where it's like, okay, now this is an emergency, a medical emergency. Sure. I need to arrest these behaviors, and we're going to provide a space for you to physically and medically safely stop using. And then right after that, it's recommendation of treatment so that we can do some of the emotional, dare I say, spiritual work that's needed to lay the groundwork to change or be ready to change once you leave this place. What I think about, though, in your experience in outpatient care is like, can you help people exit into treatment before it becomes an emergency? And how much of a challenge is that?
Helping from an outpatient setting, helping them get to residential treatment before.
Or maybe you suggesting you're seeing something unfold.
Absolutely.
And how do you know when to recommend addiction care for those people or not?
Yeah. Well, if we just look at the levels of care and the ASAM recommendations, they're pretty clear on when we would be making that recommendation for someone to go to a higher level of care. But for me, it's when, number one, they have repeatedly been unable to change the pattern of behavior that they're engaging in. So I don't always take just a abstinence-only perspective in addiction recovery. I'm in an outpatient setting, so I work with patients that aren't always in a position where they might die because of the substance. They just might have a problem with changing their behavior around it. So something I'll offer at times for clients who are not in danger of harming themselves or harming somebody else around their substance use, I'll ask them just to not use for the next week. And see if they can not use before they come into the next session. And let's say they repeatedly are unable to stop using within those weeks. Well, now we know that they've lost control over the substance use. And depending on the volume of the use and the potential impact of the use, we might then start thinking about escalating that to a different level of care. Usually we would also be seeing some co-occurring mental health challenges for the individual as well. So maybe chronic anxiety, depression that they've been struggling with as well. And we'd be taking into consideration whether they want to change or they don't want to change. The interesting thing about the work that I'm doing is that they are not mandated. I used to work in a court-mandated setting where most of the patients that I was working with came to see me because they got involved with the legal system, whether that was a DUI, public intox piece, or they got into a fight at a bar. Something along those lines that they then had a charge. Court mandated them to get an assessment piece. I would evaluate what level of care they should be in. But the patients that I see in outpatient, I don't have any court-mandated referrals at this point in time. So everybody's voluntary. They're there because they want to be there, or somebody in their family asked them to be there. One of those two pieces. And so depending on how much impact the substance use is having on their life on a daily basis and how much risk there is to that, then we're going to elevate them to the next level. I've seen people where they're drinking. I'll reflect on some cases that I supervised in the past where we had somebody come in and they were drinking on a daily basis, multiple drinks every single day, and would start vomiting blood when they stopped using for a day. That's immediate. We're escalating that to a higher level of care. They have to be in a higher level of care. Or somebody who they're drinking on a regular basis and they're having screaming matches with their partner every single weekend and they can't stop doing that. And now they're starting to miss work and work is being impacted because of their substance use. Now we're seeing that impact and we are going to escalate and make that recommendation that they go to a higher level of care.
So recommendation is a good word. Mm-hmm. What's the reality of how those recommendations are received or because again, we're not in the business of trying to change insight from a systems perspective. So how is that a challenge in terms of making a recommendation for somebody you likely believe that they could benefit from treatment?
Absolutely.
And what comes along with that?
I think I think there's a lot of systemic barriers that make it difficult for people to go to the care that they really need long term. Some of those are societally based. People have bills that they've got to pay, and sometimes being able to take off work for 2 to 3 weeks, maybe even 4 weeks, is something that would be an astronomical economic impact to them. And being able to step away for treatment is just an impossibility for their long-term survival. We could argue about that being an important investment in their future or not, but some of them cannot see past the catastrophe that would cause if they were to step away from work for a month. For some people, it's they don't have health insurance, and so the bill to be able to go is just larger than it would be. And I think probably the more minor issue is just the stigma that people worry about what it means about them if they had to go to inpatient treatment for the substance that they're using, for the addiction they're experiencing.
So when you make these referrals, how often or not is somebody taking you up on the recommendation?
Very infrequently.
So here's an ethical dilemma.
Yeah.
Let's say, the individual that when they stop drinking, they're throwing up blood is like, nope, that's not what I'm interested in. I came to you to see you for care. I want to continue to see you.
Yeah.
Sorry to ask you one of the most difficult
No,
classic.
You know what? Glad you asked, Nick. As we have it, I wrote a book chapter on this exact thing. Non-scripted, truth. But I wrote a book chapter on medical family therapy and how we apply that to substance use disorder treatment. So it's this conceptualization of what can we do to provide an increased level of care for a client who can't go to inpatient treatment, even if we want them to go to inpatient treatment. Now, mind you, I might be every other session or every session still telling the client, you should consider this as an option, and we can figure out how to make inpatient treatment, residential treatment, be an option for you. But in the meantime, here are the things that we might ask of you. So I might ask of a client to go to their primary care physician and have a blood panel done, a physical done on them to see, are they medically stable at this point in time, given the substance use that they're engaging in? Are there any healthcare needs that they have that they could be getting worked on? Then I might consider involving, especially if something shows up on that blood panel, involving a dietitian in the case, because there are nutritional impacts for a lot of different substances. And in the chapter, I go through the medical impact that different substances could have. But like alcohol use, for example, impacts the absorption of other nutrients in your body. So you might end up having somebody who's actually malnourished because either they've been replacing food with alcohol or they haven't absorbed the nutrients that they need because of the alcohol use. So I may also ask them to see a dietitian to make sure that they're getting the nutrients that they need, the care in that capacity that they also need. And then from there, other providers that we can integrate into treatment is I can have them go to a 12-step meeting or a group therapy meeting. So even if they can't go to inpatient treatment, I can say, I can only treat you under these conditions being, I need you to go get a physical by your doctor. I need you to go to a 12-step meeting 3 times a week. I need you to also find a group that you're going to be going to. And we still acknowledge this isn't the best care that you could get, because putting you in a residential care where this is the only thing you have to worry about is changing your behavior around this substance, around the addiction, that would be best case scenario. But this is our best fix for the realities that some of the clients are facing.
That felt like a really, really good answer.
Thanks.
Felt like I was like, I should go to residential care. I mean,
yeah.
I know it's a little tongue-in-cheek. It's very serious for some families.
No, also, and it is. I wish that our society made it easier for people to do a holistic, intensive refocus on changing something for themselves.
Yeah. It also has just struck me, families are searching for these answers. How do we help motivate change? How do I keep safe my loved one?
Absolutely.
There's probably a lot of partners, brothers, sisters, families of choice that are worried because they have exhausted their own individual or collective ability to motivate change, and are searching for real pragmatic, suggestions. So I just want everybody to know, I really didn't know about the medical family therapy chapter, I promise, because that was not the tee up of the century. It was just organic. But is there anything you would add, speaking directly to families who are affected by addiction in terms of how to best support somebody that's active in their disease?
So this is to the family members and to the person instead of the person struggling. Make their own changes. So what do they need to do to be a healthier version of themselves? Many family members stop taking care of themselves because they have a family member who needs taken care of because of the addiction that they're struggling with. And I think that they need to go on their own journey of making sure their basic needs are met, that they're working on their own mental health through that process. And I think the wisdom that I would like to give them is you are not going to create a disaster by setting boundaries. You're potentially creating an opportunity for growth. And growth that could be life-saving. And so although setting boundaries and saying no might not feel comfortable, it may feel like you're abandoning that person and that you're not helping them, that you're deserting them, but it might actually be the thing that saves their life because you stopped protecting them from the need to recover.
Yeah. It's hard to do.
Hard to do.
It's really hard to do. It can feel, and often it is very real.
Yeah.
And the danger is very real. But I like the way that was framed instead of you need to draw this type of boundary or you need to have this type of conversation. It's like go on your own health, mental health journey.
I think people are so afraid of consequences and giving consequences. Like I've heard parents say, I really don't want them to get arrested. Arrest would be the worst thing that can happen to them. And honestly, no, sometimes it's the best thing that happens because then they see I'm not invincible. I can't get away with this behavior. The system has said, no, I need to do something different. And I've seen it be the catalyst for change for people, especially because I worked in a court mandated setting. I saw patients where maybe they only needed level 1 level of care, maybe level 2, but they got in trouble and then they changed their life. Yeah. And they wouldn't have done that if they didn't get in trouble.
Yeah.
Because it never would have been bad enough.
Do you think that there are common themes through people who get recovery? Do you think that there are common things that are shared among somebody who get to experience, I hesitate saying make it, but surviving an active disease like addiction?
Yeah.
I really don't know the answer.
Yeah, I don't know if I know the answer too, and I really would love to know the answer. I think there's lots of different opinions on what the answer is and what people need in order to finally get there. I think belief in self and the ability to change is one. Knowing that you're good enough, I think, is another. I think that if you don't see yourself as capable of doing hard things, it's going to be really, really difficult to go through the recovery process and do a lot of new things you maybe never did before.
Super interesting. I heard hope.
Yeah.
Hope. Do I believe that maybe, just maybe, this can work for me?
Yeah.
Not confidence, and that hope is honestly part of why community is so valuable. Being able to meet and see somebody who, from a 12-step culture perspective, can share that they have a similar experience, and then you can see that they are paying their bills.
Yeah.
Holding a job and perhaps have a relationship, and you're like, wait a minute, I am not able to do any of those things and feel completely unstable. But maybe it's like that little tic-tac size portion of hope. I think that's a great thing for anybody to reflect on is does that exist? And if not, how can I create that?
I was thinking as you were talking about that, about how embedded in a lot of recovery treatment centers are there's the peer model of how do we help people recover. And there's also this piece where a lot of patients want to work with somebody who went through it themselves. And I wonder if it is part of it is hope. It's that this person understood what my experience is. This person really knows it because they lived it and they were able to do something different. And maybe that is providing hope just by seeing that somebody else has done it, has gone through what they went through and able to change their life.
Yeah. Okay, I'll shift gears. I want to ask you what you think makes a good treatment center. Like, you've been working in the field for a long time. You're making referrals, i.e., you're recommending that people go to certain programs. Likely, you're not just telling somebody to go to Google and best of luck.
Right.
You're likely guiding.
Yeah.
So what's important to you?
Aspirationally, I wish more treatment centers really did care about their patients and listened to their patients. I worry that I've had a lot of clients come back from those experiences and say, nobody really cared about me. I was just kind of another number to them, and that was my experience. And just not, sometimes there's people that'll come back from those experiences and they didn't really feel like they worked on the mental health issues that they needed to have worked on. They felt like maybe the psychiatrist changed things up in their medications just to change things up and try something different, which certainly that can be effective, but sometimes it's just changing things when they didn't need to be changed. I think the thing that I have had the experience of here at Cumberland Heights has been seeing from lots of different levels, lots of different professionals that are here, how much they care about the patient first. And I don't think that that's always the case. I think patients need to feel like they are valued and not just a number. And if they don't feel valued, I don't think they're going to experience the benefit.
Yeah. Yeah. It will be hard to engage in a process, whatever you're asking to be done while I'm here. If I don't really think that you're invested in my well-being or, you know, if there are ulterior motives to which we're all here, then I'm like, and people that experience addiction are uniquely gifted to sniff out fraud.
Yes, they are. Yes,
or
they
insincerity.
Are. Yeah.
You know, like, are you being genuine with me or not? You know, like, are we meeting in this place of, and maybe a product of that is like, just like the hard life that somebody might live related to addiction. So it's like, I don't want the fluff.
Yeah.
I don't want the check-in. Like, let's like go.
Yeah.
You know, like let's connect. So that's.
I had this theory that I wanted to do some research on and test, and thus far haven't been successful. And I don't think I've used the right methods, but I wondered if people who are struggling with addiction are super feelers, like more receptive to the reactions of the people around them, that they can feel personal energy. So if the person next to them is anxious, that maybe they are more receptive to that than this other person over here that doesn't have addiction. That maybe they're super feelers, and then when they are in this environment, they are affected by it even more, which then in recovery means they are going to need authenticity to be part of the care that they're receiving, for them to trust it.
Yeah. Yeah. That's super, super interesting. I'm so glad you're here.
Thanks, Nick. I'm glad to be here.
It's like it's been a grateful day for me.
Yeah.
I mean, most days I'm grateful at Cumberland Heights, don't get me wrong, but we spend so much time together. It's an interesting process. Like when you go through school and they're like, we spent thousands of hours together working on research projects with everybody else, you know, Nicole and Doug and the whole gang. And my fellow cohort mates, you know, especially the center for me. And then all of a sudden you're just like, that is over, you know, and where can you find and generate? That's kind of an interesting topic in itself. You know, where are you going to be able to find a culture like that, you know, where you can share ideas and all that. So anyways, it's a pleasure.
Thanks,
so
Nick.
glad you're here. Thank you for coming during Dead Day.
Yeah, that was yesterday, but today's officially.
Whatever. Yeah, so
I flew in on Dead Day.
I'm sure you have student emails to follow up on and all that, but I'd be really excited if you were able to come back. The training today was stellar.
Thanks.
Rave reviews. Maybe even figuring out a way for us to get more of the Texas Tech crew out here to do something unique and special. You know, so.
Loved being here. Loved seeing what it's all about, and
the trees.
Happy to be here, and
shout out
to see the trees.
Shout out to the trees. For those that are listening, if you've ever been to Lubbock is almost completely flat, and all the trees are not native to Lubbock, which begs the question: where exactly did all the squirrels come from? Nobody knows. Probably on the truck by truck, squirrel by squirrel.
Yeah, fun little anecdote. On my drive-in, there was a nice winding road through the trees as I was coming through here. And I reflected on how all of the driving I do is in a straight line on a regular basis.
Lubbock is literally situated on a perfect grid.
Perfect square.
Perpendicular, parallel, So that's not, you have to like really pay attention, like grab the wheel. You were probably
wow,
yeah. That's funny. Well, thank you for listening. We will link Kristy's contact information in the episode, more resources perhaps associated with what we talked about. We really appreciate those that are listening. I hope it's helpful. If anybody has any questions, you can always contact us, DM us any way that you can, give us suggestions on what might come next. Please be sure to like, follow, subscribe any of our channels. We really appreciate you guys. Love our community. Thanks, and we'll see you again next time.
Yeah, thanks, Nick.